Okay, good evening, everyone. Uh, Firstly, just to put it on the record, I'd like to thank all my fellow relief for the nice dinner and gift. Thank you, everyone. It was really outstanding, and I cannot express my thanks for you all, guys. I really appreciate that very, very much. Today, we're going to speak about venous disease. And again, I mean, you cannot apply, guys, venous pathology, treatment, management on the arterial disease. Completely different. So every time when you're dealing with a venous disease, you have to switch your side of the brain, go to the other side, and try to think venous. This is the reason why very few you see people who are good in venous and arterial. Most people, they're like, most of the time they do only venous, and people do only arterial. Lymphatic is just between. All right, let's start with Ahmed. You want to start with this one, Ahmed?
Okay, Samer. A 65-year-old man who presents with an acute left iliofemoral DVT, the risk that the patient will have recurrent DVT in the next 10 years is
Okay,
a number.
so yeah, the numbers, right? This is a simple questions. But in general, when you have a DVT, what percentage will get to, because all this number mean nothing, like 1%. 1% is for what? How often you get a phlegmangia?
1% of DVT
1%.
phlegmia.
Yeah, it's very, very rare. I saw maybe 1 or 2 cases. So 1% go for phlegmania. It's very, very rare cases, and it's an emergency if you have to deal with it. DVT, if you have it, of course, it will increase your chance of DVT after next 1 year, 2 years, 3 years, and up to 10 years. Within 1 year, it's about 15% and goes slowly the more years. The most studies showed after 10 years go up to 30%. So you just have to override this number. It's not much about this question again, but write it down, guys, if you get questions at exam. So it's 1 year is about 15%, and 10 years is go up to 30%. Any question? Not a good question. Let's take next question. Maybe it's better.
Okay.
Here we go. Oh, also a question. All right.
Okay. A 72-year-old woman with lung cancer presents with swelling in the right leg. Venous duplex demonstrates evidence of acute non-occlusive popliteal venous thrombosis. The most appropriate management of the patient is in cancer patients.
She cancer patient, okay?
Usually low molecular weight heparins.
Correct. This is low molecular weight heparins. This is just standard because it's better than what when we had only warfarin. All the guidelines they said for cancers, your first line of treatment, low molecular weight heparin. Okay, but after we have DUAC, things should change because all the trials showed that DUAC work as good as low molecular weight heparin in cancer patients. So now you have a choice either to do with low molecular weight heparin or give a DUAC. This is new guidelines. The second thing is the old teachings that always we give warfarin for provoked DVT for 6 months. Things change now, and now we give it only for 3 months. We don't have to go for provoked. Unprovoked, you have to go for life, of course. But I'm saying provoked DVT, then 3 months is enough. Okay. So with all this data, let's see what options we have. So one by one.
Redo duplex in 1 week. There is no point of doing that.
Yeah, because he has DVT, right?
Yeah. A lifelong antiplatelet therapy. This is
some people, why it is confusing, because a non-occlusive popliteal vein thrombosis. You see, it doesn't matter if occlusive or non-occlusive. Popliteal vein thrombus, you have to treat it. Okay. When you do number A, what changes the scenario and give me number A will be the right answer.
A redo?
No.
If it is Thrombosis in the
tibial
superficial system.
is no, in the tibial vein. If he tell you the same, they have acute or thrombosis in the tibial vein only. Some people, most people, they don't do anticoagulant. Just repeat the ultrasound 1 week. If the blood provoked to the popliteal vein, they treat it as TPT. If it is just stay in the tibial vein, we treat it conservatively. We don't give anticoagulants because the incidence of PE is very, very low. Okay. So if they put you on the exam, they said like tibial vein thrombosis, then my answer would be number A. Okay. So let's go to number B.
Lifelong antiplatelet therapy. Venous usually is anticoagulation, not antiplatelets.
Correct. Even when we treat them, when we put a stent, we don't give antiplatelets, right? So antiplatelets is, as I'm saying, venous different from the arterial. Really, in the arterial venous system, antiplatelet doesn't work. Okay.
Okay. Intravenous heparin bridge to 3 months course of warfarin.
Okay.
This is a cancer patient. We don't usually give warfarin.
No, I mean, if you can start, go ahead, continue. Talk about it.
Okay, D, low molecular weight heparin bridge to 3 months course of warfarin.
Okay.
Also, no need. There is the injectable ones.
So I got last. So it's
The
which
last one,
CDE?
the weight heparin
Yeah.
for 3 months. So this is the new recommendation. 3 months.
Yes. That's good. As I said, warfarin usually is not, I mean, it works, but it's not the best treatment, the most appropriate they want. Okay. It's not our first line of treatment. Warfarin is second line in cancer. So first line is not warfarin. So intravenous heparin bridge to 3 months course of warfarin is not recommended in cancer. The same for second D. E is the best low molecular weight heparin for 3 months course. Or he can give you DOAC for 3 months, also be right answer. That's why he didn't mention any DOAC because you get confused. Or if you put like D, low molecular weight heparin bridge to 3 months of DOAC, then you get confused because this will be answer correct. All right. When you give warfarin, even with the DVT, always is recommended to give a low molecular weight heparin for 5 days. Even if you get target PT in the next day or the day before, always recommend to give warfarin for 5 days before bridging to warfarin because it has anti-inflammatory effect plus anticoagulations. So when the patient comes DVT and you give him low molecular weight heparin, bridge him to warfarin, and like 3rd days INR is normal, don't stop warfarin, low molecular weight heparin. It's recommended to keep it for 5 days. Okay. Any question about these things? Because it's an important question, really. Okay, so we learned 2 things. First, will be tibial vein we treated with repeat dose ultrasound. Anything above the tibial, popliteal, femoral, iliac, doesn't matter, occlusive, conclusive, it has to give anticoagulant. The first line now is DOAC or warfarin, except for cancer, our first line is low molecular weight heparin or DOAC. And we don't give 6 months anymore, 3 months is enough. Okay. Even though here, I may argue that 3 months is not enough really because this is not a provoked. It's a cancer, and cancer will not go in 3 months. So the risk factor is still there. So most probably in the cancer, I'll put them longer than 3 months. But if somebody, I think this is what I'll do. All right. Barra, on to the next question.
Yes, Dr. Samer. A 32-year-old woman with a history of left lower extremity DVT on Dabigatran presented to the emergency room after motor vehicle crash and required laparotomy with splenectomy. The FDA approved specific reversal agent for Dabigatran
All right. Before we go there, let's talk about DUAC, because let's talk about DUAC, right? There's a lot of things, guys, you have to know about DUAC, because now it's like become our preferred treatment now. So a lot of things you have to know about it. There's a question: if we repeat with tibial vein thrombosis and found tibial vein thrombosis, what will be the plan? This is a question from the chat. They said, if you do a Dubis ultrasound, the tibial vein, and you still have, after 1 month, clot in the tibial vein, you continue conservative. The only time you change to anticoagulant if the clot provoked or provocate to the popliteal vein. But if you repeat the ultrasound after 1 week or 2 weeks or after 3 weeks, and the clot still tibial vein, we don't give anticoagulant. So the reason why we repeat the ultrasound to see if it's provocated to the popliteal vein or not. The reason why we do that. All right, so we go to this question, guys. DUAC. It's very important to know a lot about DUAC, how they excreted, the doses, how do they work, half-life, how long you have to stop them before the surgery. Do they excrete through the liver or through the kidney? What the antidote for that? So what are the 3 DUAC we have? The most common 3 DUAC we have.
We have argatroban,
Okay.
rivaroxaban, apixaban, and dabigatran.
That's correct. Do you know how they do their work? Which one are very similar to each other?
I think
you have like-
rivaroxaban and dabigatran are similar. They are targeted factor 10.
Rivaroxaban and apixaban are similar. The bicratan is different. So you only have to think about 2 groups, really. It's just the reason why it's easy to change between rivaroxaban and apixaban, because are very, very similar in everything. The only one is very different is what they put it here is the bicratan. So let's talk about Xarelto's, rivaroxaban, and apixaban. So both are very similar. The only difference is the dose. Rivaroxaban, you give it once a day, 10 or 15 or 20, whereas apixaban, you give it twice a day. This is the only difference between both. Otherwise, the same. How they clear? I mean, their bioavailability is very important to know that. Is 80 to 100% it go through the tissue. Like when you give rivaroxaban or apixaban, the majority go to the tissue. Okay? This is the reason why it does not excrete much. Only few excrete through the kidney. Only 30%. The reason why, if you do dialysis, you cannot take it out, is inside the tissue. Where the bicratan excrete to the kidney is bioavailability to the tissue is only about 6%. So the majority in the bloodstream. So it's very easy, and the majority cleared by the kidney, about 85% cleared by the kidney. There is a reason why, if you the bicratan, you can clear it by dialysis if you want. You know, patient like for some reason you do emergency surgery and you can do quick dialysis to get it out. So the bicratan is mainly in the bloodstream, straight to the kidney, whereas apixaban, Xarelto or rivaroxaban, it's more go to the tissue, and very minimum straight to the kidney, only about 30%. So you cannot, it doesn't, so dialysis will not help you to clear up this one. How does it work? Again, the same. Xarelto will apixaban, they are factor, you know what factor?
Factor 10 inhibitor.
10A, correct?
Yes.
Both the same. What about the bicratan?
Dabigatran, I don't know.
2. Guys, all this, write it down, guys, because information is for the exam. Because, you know, so it's 2A, okay? The bicratan is 2A, whereas apixaban and rivaroxaban is 10A, okay? So you have to know that. So again, let's summarize it. So rivaroxaban and apixaban, bioavailability is very high, whereas renal clearance is very low, only 30%. Both they work on factor 10A, but the only difference between both of them, one's given daily, one gives BID. Whereas the Bigetran, the bioavailability to the tissue is only 6%, whereas the majority, 85%, go through the kidney. This is very important. And usually give it also twice a day, and it is factor 2A inhibitor. All right. Now we go how we can, if you have to do emergency surgery, how we can reverse it. Okay. Well, let's go through one by one. Vitamin K, does it work?
No, it works for warfarin.
Correct. So it's not the right one. Okay. Well, let's see. What about the next one?
Prothrombin complex concentrate. It works for rivaroxaban and dabixiban, but it doesn't work for the Bigetran. It may work for abixiban and rivaroxaban.
Because it has a factor 2. But you know what BCC? What factor it has? Was the complexity. We have two types. We have it in the hospital, by the way. You can order BCC. We have two types. We have 3-factor BCC and we have 4-factor BCC. Also, guys, you need to write it down. The BCC 3-factor is 2, 9, and 10, whereas the 4-factor BCC is 2, 7, 9, and 10. This is the difference. So you have 7 is extra in the 4-factor BCC, which is called octaplex, I think is his name in the hospital, or periplex. Periplex, I think called periplex in the hospital. So you can order. So this one is good, but it's non-specific. You know, it can use for all the DUAC, not specific for the Bigetran. So if you don't have the specific one for the Bigetran, you can use a BCC. Okay.
Okay.
Factor 7.
Factor 7, it is not for the Bigetran.
Because it works on factor 2, right? We said that. That is why you have to know how they work. So if 1.7, yes, but this doesn't work. So if you give factor 7 alone, it will not help. Okay. Now this is too difficult.
Idrasozumab is a targeted antidote for the Bigetran.
That's correct. What about the Adenexa?
No, this one I don't know it.
Oh, the other is simple. You have to remember this one. Okay. So Idarosizumab, it's for the Bigetran. Well, Adenexa, it's factor 10A. So it's good for rivaroxaban and abixiban. Okay. And this is all approved by FDA.
Okay.
So Adenexa, called Adenexa. Adaki called Praxibine, Idarosizumab. It's difficult. So because it's the factors, okay? Why BCC will not be right? Because BCC will work. But what was clue in this question? They said FDA approved. So FDA approved only these two medications, D and E. BCC you can give it, but it's not FDA approved because it's work on everyone. It's not specific. Okay, but the FDA approved specific, they said specific reversal agent, then you have to talk about idarosizumab. But if they said in general, you can give BCC.
Oh,
Is it clear, guys, this point? I mean, it's a lot of information here. A lot of questions can come from this one. So you have to know again. You have to know how they work, half-life, bioavailability, kidney clearance, because effective patient renal, like patient on dialysis, you have to get very careful. Don't give him the Bigetran because every time dialysis will come out, you know. So you have to give him abixiban or rivaroxaban. That is why it's important, you know. Patient with renal insufficiency, don't give the Bigetran because it's creeps through the kidney. So you have to then you have to adjust the dose. Significantly, you have to adjust the dose. Whereas the abixiban not. Patient with the liver function, liver failure is the opposite. The Bigetran will be the best because it doesn't go through the liver. And it goes through the kidney. So the Bigetran will be the best if you have a liver dysfunction or liver failure. So you see, you have to know all the informations. How does it work? Half-life, all of them is about 10 hours, 15 hours. The reason why, if you stop the day before, most of the time it's enough. unless it has patient renal insufficiency, then you have to, so for apixaban and rivaroxaban, say 33% with the kidney, so maybe 1.5 days enough. But the begetran, 85% with the kidney, so if the clearance is very low, then maybe you have to start about 2 days before the procedure. All right. Any question?
No, thank you, Dr. Samer.
I think it's clear. DOAC is important, guys, because you use it every day and in real life, so you have to know a lot of them, how they work, when you give them, when you start them, how you reverse them, What about the fresh frozen plasma? Does it work?
What, Dr. Samer?
FFB.
Yeah, it can work.
Yeah, it can work.
Because it has all the factors.
Yeah, but what's the problem with the FFB? Volume overload. Okay? Because you have to give like a big amount of FFBs, to reverse it. So you have to be careful with the volume overload. And it's non-specific again. It's non-specific. It's like, like killing like an ant with a gun. So yes, will work. So if you don't have an option, yes. So if you have an option, I'll go with the D first. If your husband doesn't have it, then we go with the BCC. If your husband doesn't have BCC, then just give him fresh frozen plasma. It's not the best, but this is the only option you have. If you have to go for emergency, if you don't have to go through emergency, just wait 24 hours. It will be cleared by the system, so you don't have to give anything. But if you have to do emergency surgery, how do you know monitors that do it? Is any monitoring system?
You need to send for the factor level, but it is very...
Yeah. So BT and BTT is not, could be normal, could be high, it doesn't matter. So we cannot send for BT, BTT, and INR, all things. So you have to go with the timing really to decide. So if patient, like he took the morning dose and you have to go for emergency, then you have to give anticoagulant. But if you get like yesterday and today has for appendix, but didn't take today dose, I think I'll be fine. I can go just with a surgery, we don't have to reverse it. So we don't have blood. We have a blood test like, factor 10 or factor 2, but it's very expensive, not available everywhere. So it's not practical. All right. Let's go to Yahya. Okay, yeah, let's go to this one.
Okay, a 45 years old man with a history of deep vein thrombosis while on anticoagulation had a retrievable IVC filter placed on prior to hip surgery. The filter is no longer required and has been in place for just over 7 months. The factor that is most associated with retrieval failure is?
Okay, let's give it to Bara. He just have a case today. They took the filter out, All right, so what makes the filter difficult? What the most important part, which is make removal of the filters difficult?
The duration.
In general, duration, yeah. The longer it's very difficult to take it out. There isn't, most people after 7 months usually is a cut. After 7 months become very difficult. But some people, they can retrieve it even more 7 months. But then you have to use something different technique. Like sometimes they use a laser to cut the limb, so they're able to take it out, Before you take the filter, what do you have to do?
CT.
CT. Yeah, CT or a venogram. I'm going to take it out anyway. Yes, you have to be sure there's no clot there, because the clot, you don't take it out. So you want to be sure that the IVC is open and it's not clot, captured by the filter. Because then you cannot take it out, or you have to lyse this clot before you take it out. Does the filter prevent PE?
The major
The major PE.
Yeah.
Not the major, what we call it? We call the fatal.
Fatal PE. Yeah.
The IVC is just prevent the fatal PE, but does not prevent PE because stress is too wide, so very small PE can go easy. And the second thing is a lot of collaterals, so sometimes you can pass it through it. But all will be like a small, because the big one will be you need an IVC, you need a big vein. So really IVC, it does not prevent PE, it prevents the fatal PE. So that's important. Okay, so let's go through them again one by one.
Type of retrieval filter. No, the filter tilting greater than 30 degree.
Not really. Now they take it even at
It's
more than
difficult,
even
but
90 degrees.
failure.
It's difficult, but it's not, you know.
Failure.
Yeah, it's not failure. Yeah.
Time sense filter placement. Yeah.
Okay.
Filter thrust protruding
Good.
through the IVC.
Okay. And look, all of them, they are retrieval failure, but they said the most associate, you know, the most common. Well, otherwise, all of them can cause failure. I mean, if it's tilted more than 30 degrees, be difficult, could be failed. Protruding could be failed. Above or below the renal, I don't think make a difference. But the most associate factor is the timing. This is really the most, because it become fibrotic and stuck, very hard to take it. The other thing, tilting or filter out of the IVC is not a big deal, because if it's not been there for a long time, the moment you capture and collapse, this limb will come out from the IVC. And even if you have injury to IVC, this is venous system low pressure. This will seal, you know, so it's not like an arterial aorta or something like that. Okay. You know, now one way of now treating type 2 endoleak, they go through the IVC. You know that? Are you here? Did you read about it?
Yes, Dr. Sam.
Yeah. So sometimes they go make a hole in the IVC and go to the aortic sac to treat type 2 endoleak. All right. Any question?
Thank you.
Okay, let's go next one. Who's that? Sama. Sama, I want to take next question.
Yes, Dr. Samer.
Where is it? Let me see it. Oh, ooh, okay.
Okay, a 30-year-old female smoker with current oral contraceptive use present with the pain to the left leg for the past 2 hours. Iliofemoral deep vein thrombosis is diagnosed by ultrasound. Pulses are not palpable in the affected leg, but are palpable in the contralateral leg. She has a mild paresthesia below the knee and is insensate to her toes. Which does not improve with therapeutic unfractionated heparin administration. Figure her motor exam is intact. The next best treatment option is
Okay. Well, from the picture, what do you think she has?
phlegmasia. Phlegmasia.
Serola Dorans, right?
Serola, yes.
Yeah. And this is what? This is an elective or emergency situation.
She has
Like
emergency.
when you get patient like that, huh?
She has a pulseless and she has a paresthesia.
Yeah, they can lose a leg. I mean, this is
Yes.
can give you a compartment syndrome, even, you know.
Yes.
So, did you see any case in your? Oh, you mean only 2
No,
years?
no, I didn't see
Yeah,
any
I
case.
think I saw only 2 cases. Also, it's very rare. But when you come, it's just treated like an acute limb ischemia. So you have to take it seriously, you know, when you get to this point. Especially now, you know, you can have it's still the motor function is still intact, but if you wait longer, then become irreversible. You know, when the motor function is gone, then it's too late. So again, it's like an arterial system. You have to treat it before you get to the motor exam and nerve damage, and then you have a major issue. Okay. So how we treat them? Treatments, yeah. So
Yes, she has a iliofemoral DVT.
okay.
So she's not responding to therapeutic unfractionated heparin. So we go to the next step, either thrombolysis or pharmacomechanical thrombectomy.
Okay, but look at that first. You know, I mean, well, let's go through the step, and then we go through it. Let's go first.
Yes,
One. What do you think?
4 compartment fasciotomies and open venous thrombectomy.
Mhm.
Not
Let's leave
to
it.
take this lesson.
Okay.
Direct oral anticoagulant work.
Which is a good option.
Catheter.
This patient.
Yes, catheter directed
No,
venous.
just a second. You said yes. This is a good option to give her DUAC. That's
For
it.
me, no, it's not a good option.
No,
She's
it's an
already
emergency,
started on therapeutic anticoagulant, so.
And the most important is the emergency, Sama. Okay, so we have to deal with it. We cannot give anticoagulant. Like patient goes acute
Yeah.
ischemia, treat him with heparin. It's not a treatment. Okay. Yes, it's
Yes.
adjuvant treatment, but it's not the treatment. Okay.
C, catheter-directed venous thrombolysis. It could be one of the options for treatment with this
Yeah,
patient.
but look at now. She already has a venous, but look at that, Osama. It's too late. Look at her leg. The leg is already red, swollen. She already start losing the sensations. You know, it's a venous congestion, like a compartment. You know, it's a real compartment. So it's not time for thrombolysis. You know, thrombolysis when you have a normal leg swelling, when you get cirrhosis, you have to do it as again like a compartment syndrome. You have to do it as soon as possible. So you can put her like for 48, 24 hours. It's not a good option, you know. If it's not, especially she will start losing sensation, you know, right? And the sensation in her
Yes.
toes. Yeah. What exam is still in there? Okay.
Open mechanical thrombectomy.
Okay.
The last one, Palmer procedures.
Okay. Well, let's talk. You know what Palmer procedure?
Yes, it is venous bypass from the right to the left side. Using either
we do use either what?
Using bypass from the venous system. Saphenous, using the saphenous from side to side anastomosis to the venous system.
Okay. So in Palmer procedure, you harvest the vein, not completely, only cut one side. You don't have to cut the other side, correct?
Yes.
Because this is a venous drainage, right? So you don't have to reverse it because it's a venous. So you just dissect the vein, like let's say the left leg, like this leg, okay? So it has a cerebral lines, right? So what you go to the right leg, you dissect the vein all the way down to the knee, like it all the tributary, make 2 groin incision under the skin like fem, and you take the vein and you pass it under the skin all the way to the left side and you connect it to the femoral vein, common
Yes.
femoral vein, okay? So this is the Palmer procedures. So they have only one anastomosis. Again, you don't need to cut the junction of the saphenous on the right side because this is the flow, right? The action flow. You don't have to reverse it. You put it inside. Correct?
Yes.
All right. So this is Palmer. Sometimes if the vein is too small, what you do? You do a graft.
Saphenous.
You do a graft. But what's the
Yes.
problem? You do like fem graft. You put like a BTFE graft. What's the problem with the graft? First, you need like 8mm graft. But the problem is the venous system, right? So this graft will clot, it will not stay open. So what you do to keep it open, you do a fistula.
Maybe you can do fistulas.
Yes, so you do a fistula to keep the flow open. So if you decide to use a graft because the saphenous vein is too small, then you use PTFE 8mm graft and you create a fistula so you can keep the flow to prevent clotting. Okay? The third thing is that they have called modified Palmer procedure. You know what the modified Palmer?
No.
Modified Palmer is the same, but instead of you suture the saphenous vein to the left common femoral vein, like in this situation, you cut the superficial vein, femoral vein on the left side with the common femoral vein, and you do end-to-end anastomosis between saphenous vein and the left between saphenous vein and the left superficial femoral vein, end-to-end anastomosis. You know, so this way they think it's more physiological, and so something called modified Palmer procedure. Again, I mean, all this procedure really we do them these days now because now we are very good with thrombolysis, with you know, with stenting. But what the problem is all this, why it doesn't fit in this patient? Why we can't do it in this patient?
The Palmer procedure?
Do a Palmer. Palmer procedure here.
Didn't give me any information about the iliac system in the contralateral side and also
everything's open. Everything's open in the contralateral side. Because you see, when you do a Palmer, the problem should be in the iliac, not the femoral. Because the problem with the Palmer procedure that you have no outflow. So the SFA, profunda, superficial femoral all open. but you have common iliac artery, thrombosis, occlusion, injury, ligations, then you need to relieve the pressure from the leg, so you do this one. But if you have a clot, like in this leg, in the superficial femoral vein or popliteal vein, and you get to the phlegmatic rolla, then the vein, so even if you do PAMA, will not work because there's no flow, because all the vein in the left leg is supposed to drain to the right is thrombosed. So PAMAs work only if you have an iliac, only iliac. Either thrombosis, occlusions, injury, ligations, they will work. But when you have a DVT below the groin, then palmar procedure will not work. All right?
Yes.
All right. So in this patient, really, I mean, this question, by the way, is wrong because let me see what they put the answer first. They put D, open. Open mechanical thrombectomy. I don't know what mean open mechanical thrombectomy because it's supposed to be percutaneous mechanical thrombectomy. Yes, you can do mechanical thrombectomy, percutaneous. When you do an open, we'll just do an open thrombectomy, venous thrombectomy. So most of these patient people, they do mechanical thrombectomy, but percutaneous, they go there and try to clean up the clot as much as they can to relieve the pressure. Of course, they go from popliteal vein. They puncture it and they try to clean up all the clot. If they cannot, or you don't have a thrombectomy device, I don't think time for thrombolysis, then you take her for open thrombectomy. And always you have to do fasciotomy or think about fasciotomy, okay? Because always the leg is, this is a venous, so leg is always tense. So always you have to do fasciotomy with this kind of patients, why the open thrombectomy sometimes is difficult? Because
the valves. Yes,
because of
it's
valve.
different from the valves.
Right, we have to go against the flow. But when you have a DVT, you have thrombosis, then the valve is already destroyed. So I don't think thrombectomy. You can still do thrombectomy, even though you go against the valve. You still can do thrombectomy. You just do groin incision open, do thrombectomy, clean as much as you can, and then do fasciotomy. So I think fasciotomy is very important. The last thing, let's say you don't know how to do open thrombectomy. You don't have a percutaneous thrombectomy device. You don't know how to do open venous thrombectomy. At least do fasciotomy. It's the least you can do to save the leg. Then later on we can, because swelling, but what kills this leg is a compartment syndrome. Like thrombosis, we can live with it, but the main is different from the arterial. So the venous, the main issue the venous can cause when you get to phlegmatic cerebral dolans is a compartment. The reason why the nerve get damaged and then you can lose a leg. So if you don't know how to do open thrombectomy, at least do fasciotomy. Okay.
Okay.
Any question?
Dr. Samer, if it was a graft, what kind of fistula you would use? Between what and what?
It's a good questions, So usually, because you're going to do what's the name? The vein, you're going to do it from the right, from like this one is going to go from the right to the left, but the flow is supposed to go from the left to the right, correct?
Yes.
So this one, you create a fistula between the femoral vein and femoral artery, in the groin. But the problem with this one is that if you want to close it, because you have to close after a while, it will be very difficult surgically, So what the people, they do now, they put a small graft, BTFE like 6 millimeter, small BTFE graft, between the common femoral artery and the saphenous vein, which you do your bypass, where your bypass. Because this one will keep a flow, but if we want to close later on, you can go percutaneous and put coil in the graft and you can close the fistula. But if you do surgical anastomosis, like side to side, then if you want to close it, then you have to go back again through the groin. And usually it's difficult. So most people, they do like a loop graft between the common femoral artery and common femoral vein or the saphenous vein, depending where you do. If you do palms with the common femoral vein, then you can do just a small loop graft between common femoral artery and common femoral vein. If you decide to do modified palm procedures, modified palm procedure and palm procedure, when you do a vein, you don't need an fistula. Fistula only when you use a graft. And when you use a graft, you have to do it to the common femoral vein. So the best way to do is just get a small graft between the common femoral artery and the new fem graft, you put it, make like a loop 6 millimeter graft, so you can close later on percutaneously. You don't have, or you make small incision and you ligate it. You don't have to go through the groin incision again. Okay.
Can this work, the palmar procedure, Dr. Samer, with incompetent saphenofemoral junction from the recipient side?
From the recipient, this recipient, it means the left leg, like in this one.
Yeah.
No recipient, yeah. If they have incompetent,
If the
yeah, I
saphenofemoral
think so.
junction,
Yeah, it doesn't matter because you mainly do it for the iliac, really. When you top palm, procedure is for the iliac. You have iliac problems, you know. So yeah, I think you can do it. Yeah. Again, I mean, I didn't see it. I never did in my life, really. I never even saw anybody does it. I think it's a historical. I don't think anybody does it anymore. Did you see anybody or anybody see any palm procedure? Because for me, they were clotted very quick. So I don't have experience with this. All right, let's keep going. We go back to Ahmed. So here you are, Ahmed, you are. Let's go to number 6.
Okay, a 34-year-old woman with long-standing varicose veins and past history of DVT, 10 years prior, presents with a painful, throbbing left varicose veins and the great saphenous vein distribution. Ultrasounds confirms acute thrombosis of varicose vein tributary extending to the thigh, GSV, 10 centimeter in length and 5 centimeter from the saphenofemoral junction. The best treatment of this patient is anticoagulation.
Why?
A, hot compresses. This is symptomatic treatment.
Well, let's before you start. How it is in general, SVT, superficial SVT, superficial femoral thrombophlebitis. How we treat it?
If it is short and distant, you can just repeat ultrasound after a while.
SVT. Okay, superficial venous thrombosis.
Yes,
SVT.
if it is short one and distal, you can observe it.
No, but patients, they come, what are the symptoms they come, patient? They come with what?
Pain, usually.
Pain. It's very painful, right? And tender. See, red area, tender, very painful. So you have to treat the symptoms. You treat symptoms, right?
Yes.
How we treat a symptom?
NSAIDs.
And hot compression, okay?
Yes.
So what hot compression? And we give anti-inflammatory, okay? Non-steroidal anti-inflammatory drugs. This is a normal treatment for SVT. All the patients come SVT, very tender, you know, hot area, very tenders. Then we give him non-steroid and hot compression. The question now, do we need to give anticoagulant or not? Then we have to look for risk factor. And these people, they have all the guidelines, they put a risk factor. This is the only time this risk factor you have to give anticoagulant for SVT. Otherwise, all SVT should be treated conservatively, except the patient who has risk factor. Okay? The question now, what are the risk factors? You mentioned some of them. Well, let's talk about some of them. Everyone has some. Let's talk about it. So what the risk factor you said? The links, right?
Yes.
What the links you said? More than what?
I think 5 or 10 centimeter. 5.
No, 5. 5. Anything more than 5, they consider is the risk factor. So they prefer to give anticoagulant. Second things, closure from the saphenous femoral junction. The closer, it's risky if you can go, the clot can go to the deep system and give a PE. Okay. The links, I think usually 3 centimeters. If it's less than 3, it's risky. So if you have a clot close to that, less than 3 centimeters from the saphenous femoral junction, you have to start on anticoagulant. Or if the SVT more than 5 centimeters, you have to start anticoagulant. This is 2. What else we have? If he has a previous history of DVT, like this is a risk factor. If he has DVT before, then high risk he can get other DVT. So if the patient has history of DVT, then and he comes with SVT, the previous DVT itself is an indication to give him anticoagulant. If they have a cancer, also, because cancer, they make patient hypercoagulable. It's also an indication. These guys write it down, all these risk factors. So cancer is a risk factor. Some people, they put a male patient as a risk factor. Age more than 65 is a risk factor. And if you have SVT in non-varicose vein, this is the main risk factors, people. But usually in the exam, they will concentrate on the links mainly. They like this one. The links, the most important is the links more than 5 or the closer than 3 centimeters from the junction. I think if somebody can make exam, should be play with this 2 number, because this is very, they like these 2 numbers, you know. Otherwise, all of them we treat them with what's name? With anti-inflammatory. Okay, so let's say if you want to treat them with anticoagulant, what do they give them?
You can give Duox or low molecular weight.
Low molecular, usually recommend is low molecular weight, Fonda Paranex, or give rivaroxaban, as you said, Duoc. It's like a cancer, we give it, okay? But the only how is different. How long we give it to them? It's important, guys, to write it down also. How long we give it to them?
Short course.
Yes, 45 days, okay? So 40, we don't go 3 months like DVT. So SVT, if it's, again, we have to treat them. We treat them with Fundaparanx or rivaroxaban. Fundaparanx 2.5 milligrams sub-Q once daily, or rivaroxaban 10 milligram PO once daily for 45 days. These are recommended dose. Or you can give him low dose, low molecular weight heparin also for like 30 days. This is what the most recommendation are. Any question? You see, guys, how much in the venous system information, a lot of information in the venous system, because we don't deal with them every day, and there's a lot of information in the venous system. And all right, so let's go. 1, we said 1 is wrong, B is wrong, C. Ahmed, still with us? Ahmed, it's gone. Barra, you want to continue?
Yes, Dr. Samer.
Yeah, okay. C.
Repeat ultrasound in 4 weeks.
Again, this is not a good option because he already has a risk factor. But
Yeah,
anyway, if you
of the
decide not to treat it and you decide to be like you are not questionable, like borderline, you know, you're not like maybe it's like 5 centimeters, the links exactly at the borderline, 5 centimeters from the ACP, risk factor is not much. You want to be ultrasound, you don't wait 4 weeks. 4 weeks too long because you can get the PE and DVT. So you beat in 1 or 2 weeks. And then you see any propagation or not, the clot is getting longer, it's getting closer to the junction. But 4 weeks is too long if you decide to go this way. Okay. D.
therapeutic anticoag. This is the correct answer.
Okay. And E.
Elastic compression stocking.
Yeah, it doesn't. Nobody proved that elastic compression stocking helps. Even become painful because it's very painful area. If you give them compression stocking, be more painful. All right. Any question
Yes,
about
Dr.
guys?
Samer, we
Yes.
can apply the same rule for thrombus after endovenous ablation.
Yes, yes, because of thrombophlebitis. And this is the reason why, really, it's good questions. When I talk to a couple of people, you will not be surprised, it's a good number of vascular surgeons who do ablation for varicose vein. They put patient on low molecular weight heparin for 5-10 days. Because they seem like SVT, because you're creating a clot, which is very close to the SVT junction, right? Sternofemoral junction. So there's always a risk. I don't do that, but when I talk to vascular surgeon, many people, they feel comfortable, like Isam, Tanya, they always used to do with patient on low molecular weight heparin for at least 5 days after they do venous ablation. So I don't think I recommend it, but if patient like high risk, if he has previous DVT, if he has a cancer, again, old patients, doesn't mobile too much, it's not a bad idea to put him on low molecular weight heparin at least for 5 days after varicose vein ablation. Okay. Any other question?
Okay.
All right. Okay, it's you. Let's get to the next question. Yeah, number 7. Okay.
A 55-year-old man with a 40 back here smoking history present with the head and neck swelling that has been worsening over the past 8 weeks. Symptoms are not debilitating. He underwent an evaluation consisting of CT chest, bronchial washing, and lymph node biopsy that demonstrated superior vena cava compression related to lung cancer. Venous duplex does not demonstrate evidence of upper extremity DVT. The mainstay of treatment, so this is superior vena cava syndrome due to malignancy.
Correct. Is any clot there?
There is no clot, only compression by the tumor and lymph node.
Correct. And is he okay, or is very bad situation?
He is not debilitating.
Okay. So it's not in a rush to do anything, right?
Yeah.
Usually how we treat them?
Those patients usually chemo radio with steroid.
Right. Radiotherapy, right? Because they're responsible for bronchogenic cancer, radiotherapy. If he cannot sleep or he cannot breathe or combine his breathing, then no, I'll do angioplasty and stenting, okay?
Okay.
But if you have is not deblating, because the tumor will shrink with the radiotherapy, then this compression will go away. So why should we put a stent? And Bish has a cancer, high chance of thrombosis with a stent, right? He's hypercoagulable. And the bronchogenic carcinoma usually respond very well to radiotherapy. But if he comes same scenario and he said Bishop cannot sleep at night, he wake up with a shortness of breath, shocking, when he, sleep, and buffers in his face. Some people even they get stroke from the venous congestion. Then yeah, I'll go there and I'll do a stenting. Your balloon expandable or self-expandable stent?
In the venous, it is self-expandable, but for this patient, maybe I want accurate positioning of the...
No, not accurate position. What is important? If you hold your hand with a self-expandable stent and you compress it, what happens? Does it compress or not? It will compress, right?
Compress, yeah.
Yeah, so when you have something compressive from outside, especially tumor, we're not talking about like May-Turner syndrome or the artery just compressing, Talking about a tumor. Tumor how hard, like a rock. So if you put a balloon self-expandable stent, I think this will be compressed. So I will use a balloon expandable stent in these scenarios. I will not use a self-expandable with a tumor, Okay. So C, enoxaparin.
No.
No need, because no DVT, right?
Yeah.
And last one.
And open venous reconstruction also not indicated.
No, it's not indicated unless if he has, especially a cancer patient and he's almost terminal, So I don't think so. So best way to give radiotherapy. And A or B, depending on what scenarios they present to you, but A and B should be your right answer. All right. Any question?
Dr. Samer, do we have balloon expandable venous stent or we use arterial stents?
It's a good question. Yes. We have life stent. Life stent, they use the venous system. It's a balloon expandable stent. The most important, what the lengths you use, 20, 40, 60, 80. In venous system, always guys use a long stent. Don't use a short stent because they can move and they go to the heart. Always the venous system, we don't use 40, always 60 and above. Even if the lesion like 20 centimeter, I will never put like a 40 stent. Always put like 60 or 80 because you need the stent to be, because venous system can dilate very easy with a volume over volume, so the stent can get loose and go away. So sizing is very important in the venous system. You need to oversize always at least 10 to 15% of the size of the vein. So we don't put like an arterial 1-to-1. Like iliac 8, we put 8. Venous, no. Venous is 14, we put 16, put 18. Always you oversize. And always we use a self-expandable stent, except for this when you have a tumor, then you use below expandable stent. But always use a long stent to stabilize it, because it's very easy to embolize to the heart and then be in big trouble. And I saw a couple of cases. It happens, not like never happened. It happens, and went all the way to the right ventricle. They have to go there and take it out. All right. Any other question? We still have time. Okay, let's keep going. This is nice. Number 8. So who's next now? Yahya, right? Yahya.
Yes, Dr. Samer. A 42 years old woman undergoes pharmacomechanical thrombectomy for iliofemoral deep venous thrombosis. Follow-up imaging include IFAS, which demonstrate more than 50% segmental narrowing in the iliac vein. In addition, IFAS demonstrate normal adjacent iliac vein diameter measurement ranging from 8 to 14 millimeter. A decision made to stent the iliac vein, the size of the self-expandable stent used should be?
Okay. So I'm telling you that's compression maternal. So we can see the compression here. It's maternal. This is the artery here, right? And this is common iliac vein. And they measure it, they found 14 by 8. Maybe they measure this one. Now this one's circled, so maybe they measure this one. So the question, when you have this size of the IVUS, how do you size it? So how do you decide what stent you use?
Balloon expandable.
No. I do like self-expandable. No, balloon expandable, no. Venous system always self-expandable because you need to oversize. You see, and the venous system, it can change its volume with the fluid intake or your volume overload. So you need some stent which is flexible. She can, accommodate the change in the size of the vein. And second thing, you can oversize. You cannot oversize with a balloon expandable. You oversize only with a self-expandable stent. So the venous over then to choice is very common in the venous system. So in the venous, and the second thing, so always we use self-expandable non-covered stent in the iliac system in general. So iliac system, two things you have to know. First, you have to use the dedicated venous stent, because the manufacture of venous is different from the arterial system. And second thing, it has to be self-expandable, because the stress should be the least, because you need the least stress between the less metal will be less chance of thrombosis. You see, the balloon expander has a lot of metals because to fix it, to make it stiff. When self-expander, you have the least bridge between the stents, so you have less metal, and they're more flexible. Then we use non-covered stent because a lot of collaterals in the venous system, so you don't want to close this collateral. So you need non-covered stent. And the last thing has to be a long stent. We don't use short stent. Okay. So let's talk in general. When you talk with the iliac, we don't think about like iliac artery. We don't do like 8, 10, 12. No. Iliac vein, you have to talk about 14, 16 in general. Even forget if you don't have an IVUS. In general, when you talk about iliac vein, common iliac about 14, 16. External iliac, 12, 14. IVC talk about 20, 22. So let's remember this guy's number. Okay. And when you have like, stenosis, the common iliac, we don't use the 8 balloon. We use like 10, 12 balloon, big balloons. The other thing is different arterial from venous system. In the arterial system, 90% we get away with that ballooning. We try not to stent as much as we can. Always we try to avoid stenting in the arterial system. In the venous system, it's completely the opposite. 80% we stent. Ballooning will not work. Ballooning, it's beautiful. It comes after a week, will come back because it's fibrosis, not an intima hyperplasia. We can break it with a balloon. It's fibrosis. So you open it, will recoil. So recoil in the venous system is very, very high. So you have a very low threshold for placing a stent in the venous system, but have a very high threshold for placing a stent in the arterial system. It's completely different. I think that's all. Any question?
Sir, how long within the IVC you go with the stent up?
That's good. The problem was that the compression usually it at the origin, and the origin is an oblique. So if you put it in the lower, let me show you. Maybe create an image. Let me see, so you can draw it because an important questions. See, you can do this. Okay, you see my paper now?
Yes, we can see it.
Okay, let's do some drawing here. Let's talk about Palma. I'm drawing now. Okay, so Palma stent, Palma procedure. So you have the femoral vein deep, and you have the here. Okay, come on. And then you have the change the color. And you have the cephalus vein, right? You have the cephalus vein. Okay. Right? On the other side, we have the same things. So you have the iliac here. So when you do a Palma procedure, this should be an occluded. We talked about it before. It would be an occlusion here. If you have occlusion here, it will not work because you need to flow this one out. So usually you have a problem here, the iliac, either occlusion, stenosis, whatever. So what you do is just you go and you harvest saphenous vein, you cut it from here as low as possible, and you break the saphenous vein like that to the femoral vein here. That's all. Again, it's the most to the femoral vein. This is a Palma procedure. If you want to do modify Palma, then take this color. It's the same, but instead of going to the femoral, you take this saphenous vein and you go to the superficial femoral vein. You do it like that here, end to end, and you ligate this one here. So you cut it here, you cut the superficial femoral vein from the common, and you do end to end. So the flow is better. You come from the superficial femoral vein through the vein all the way to this system here. So this is a Palma, and this is modified Palma procedure. And all of them, we do them mainly for the iliac. Okay, we don't do them for anything below the ankle. All right, let's go back now to the next one. Any question about Palma? No. If you decide to use a graft, then use a graft. Okay, and then again, we said we do the fistula there. Okay, so what was the question? Why we draw this one? I forgot.
عشان اللينث of stent within the
length. Alzheimer يشتغل. عشان دخلنا موضوع تاني. So this is let's see. Let's get it drawing. Let's start with you have the aorta, right? Go like that. Go like that. And then you have the IVC, right? So the IVC should go this way. And go this way. So, yeah, let's go this way. This one should go this way. Okay, right? Yeah, so it's compression of the left with the right to an iliac artery. So what I'm trying to say is IVC is like, so the compression is here. So if you put your stent this way, let me put the color this one blue. So if you put your stent like that, still compression here. So really, because stent doesn't go oblique, it go like passes like that. So you have to go all the way up to here. Picture is not right. It's not good. Let me just do a good picture. Where's the eraser? Let me do it again. Sorry, guys. water. This is IBC. Obviously, it's very close here. Anyway, so sorry guys, I'm not getting out. So this is IVC. So if you put your stent here, you lose this part, still compressed, this part still compressed. So you have to go with your stent up to here, and you have to put it with IVC. So the stent has to be like this way. To be sure that you cover the whole IVC. So always to decompress the maternal, you have to go to IVC. And this will, there's why you use uncover stent, because you're covering the contralateral limb. And they have classification 1, 2, or 3, how much you protrude inside, third, 2/3, or full. Of course, don't over all the way there. There's some people, they said this increase your chance of DVT on the other side because of the occlusion here. But nobody showed it 100%. That's why some people, they do a kissing stent, but it's not recommended. And now they have what we call it an oblique stent. Company, they came with that, which is stent come oblique like that. So the oblique stent. If you have it, I think it's the best option. See, the stent come this way. So in this way, you don't cover the contralateral limb. But we don't. But the normal stent will go this way. But if you have oblique stent, it will be fine. Does this answer your question, Ahmed?
Yes, Dr. Samer, thank you.
Okay. Sorry, my drawing is not the best. All right, let's go back. Where was that question? So what answer for this question? So what do you think you should use?
The
Stent?
sizing 10 to 15%, around 16 to 18.
Yeah, about 16. What the links?
At least 60, 80.
60. Yeah, 60, 80, above 60, you know, but not less than that, you know. Of course, you measure with that. Does the venogram is good to do diagnose May-Turner syndrome?
Better with IFAS.
Yeah, because venogram could be false negative, false positive. Venogram is not a good one. Even CTV, the best way is MRV, but we don't do it because it takes a long time. But you see, we do CT with the venous. But the most important for sizing is to go with the IFAS. We don't go with the CT. We don't go with anything. The IFAS is the best way for sizing. So if you get files like 8 and 10, you go with a larger number. So the larger number of 14, and you oversize 10 to 15%. So I'll use mostly 16. Okay. And the links, it depends how links my lesion, but I will not less than 60, 60, 80, 100, depending what's the lesion. But I will not use like 40 or 20, at least 60 and above. All right, let's see what option. Let's go here.
Okay. All the length 10.
The same. So they give you a long one, you see? That's good.
Yeah, 8, 10, 12, 14, and 16. We'll go with 16.
16, because you don't give same size 14, so oversize. All right, that's a good question. Okay, we'll go back again to Samer. All right.
Okay, a 53-year-old woman with history of iliofemoral deep vein thrombosis 10 years ago. Present with weeping ulcerated wound of 2 months duration. Anatomy involves the deep veins, and pathophysiology shows deep obstruction. The clinical, etiological, anatomical, and pathophysiological clinical classification of this wound is.
Okay, SEEP is very important, guys, to know SEEP. They always ask about this in the exam. SEEP, they love it. Anytime they talk about like Rutherford classification for us in arterial, in the venous SEEP classifications. You know, a lot of new classification, but SEEP is the most important. So do you remember it, Usama? We have to go through.
Yes.
You know what? How many steps? How many?
Yes.
You know.
C clinical divided into 6.
Okay.
C1 reticular veins, C2 varicose vein, C3 edema, 4 divided into A and B, A eczema, B
Make it simple.
sclerosis.
Make it simple. Let's go A and B. Let's go 1, 2, 3, 4, 5, 6.
Yes.
So you say
1
4,
reticular veins,
correct.
2 varicose vein, 3 edema, 4 eczema, sclerosis, 5 healed ulcer, 6 active ulcer.
Correct. So what we have here?
We have an active ulcer, so
Right.
it is
So C6.
6, yes. And
Okay.
etiology either
It's a venous hypertension, right? I don't know what etiology. I don't have. There's no study here. It's a venous hypertension for sure. Right? It's a venous system, right?
yes.
It's a venous hypertension. Or it's a chronic, you know. How do you know it's not a venous, not arterial ulcer from looking just to that? How do you know it's not an
The
arterial?
location of the ulcer in the medial malleolar and
What
lateral.
else? What else?
And the swollen leg.
Okay, what else?
And
Most important is pigmentation. Okay. See pigmentations, yeah, kind of hemosiderin, because the stasis in the blood, when the blood stays in the leg for a long time, it breaks down. The hemosiderin release from the RBC and give you hemosiderin. Stasis, you see this one? Look at the skin color here, skin color here. This is typical for venous ulcer. When you see hemosiderin here, it's a venous ulcer without even doing any test, you know? And this is non-reversible. Even if you treat it, it's like a tattoo. This will never come back to normal. It's always stay with this color. Okay. All right. So C6. Okay. This is an easy one. All right. Let's keep going so we can get more questions. So we go back to Ahmed. Ahmed.
Okay.
Ahmed is still there?
60-year-old man presents with recurrent ulceration to his left lower extremity after being recently discharged from the hospital. He has history of lower extremity DVT 25 years ago. Currently, the wound has granulation tissue at its base. There is no evidence of erythema, flatulence, appreciable drainage. Venous duplex demonstrates evidence of chronic femoral vein DVT without evidence of superficial vein reflux or perforator disease. The most appropriate is wound care, Una boots.
Yeah. Una boot. Okay. You know what's Una boot?
Yeah, it's a rub. They rub it over
How
an
many
actual...
layers? How many layers?
I don't remember.
Yeah, 3 layers. Okay. 3 layers. One of them will have a zinc. It's white. It comes like the I don't know if you saw it. In Saudi, we don't see much venous because you have a lot of arterial. Very rarely you see venous arterial. Either you see arterial or venous because it's completely different pathology. The reason why in Saudi we don't see venous disease because you have a lot of diabetic, a lot of chronic arterial disease. The reason why you don't see a venous disease. Instead, we saw a lot of venous, hypertension and venous ulcers. And it's very hard to heal them. So we use Unabut a lot. Unabut is a 3 layers. The first layer is like a white, like a wrapping with a white material, which is zinc. It has a zinc. It's like a little tabshur, like abyad. So you wrap the leg first with that. Then you do second wrapping with just like garlics. Then you do an ace bandage. You need to put a pressure. So it's a 3 layers compression. Some people they put 4 layers, but it's become too much compressed. But you need at least 3 layers. And you put it there and leave it for a week. Some people leave it for 2 weeks and they change it every week. And this is the only way because this compress the ulcers. Of course, in the meantime, you have to deal with that problem. So you have to look for venous reflux. Then you have to deal with it. This is no. And the most important, any perforator. Then you have to treat the perforators. The only time we treat perforator, guys, if we have an ulcer. If there's no ulcer, you don't need to treat perforators. So anytime you get a patient comes with a varicose vein and she has an ultrasound and she has a reflux, in the superficial vein and perforator. Don't worry about perforator. Don't even think about it. Just go and treat her superficial femoral vein, superficial in a greater Simmons vein reflux or lesser Simmons vein reflux. So when the report comes with a perforator reflux, don't even look at it. Don't worry about it. Just concentrate on the superficial venous system. If she has no ulcer, if she has an ulcer, then you have to look at the perforator in that area and you have to treat it. All right. So this one is what answer will be?
A, leg elevation, patient will need, but the most appropriate treatment.
Yeah.
No need for antibiotics, not infected. Compression stocking will be needed, and then a weekly changes. I would choose D.
Right. And
then E, great it is competent, Kata Professor.
Competent, so you don't need that. Right.
Yeah.
Okay, let's go to questions. Let's see if I can get more. They're only like, I think, 27, so we can go at least halfway. We can finish them next time. Who's after Ahmed?
I'm the one.
Go back. Go ahead, Barra.
يلا. In longitudinal epidemiological analysis, the factors that most associated with progression to more advanced clinical etiology, anatomical, and pathological classification. Clinical class in a population of patients with varicose vein and chronic venous insufficiency is?
Yeah, this question, I want to tell you, what the most common reason for the venous hypertension? What do you think is the most common?
I think prior DVT.
Yeah, prior DVT, right? I mean, all of them can cause that obesity, but the most common is prior DVT. All right, so it's simple. Let's not waste our time with this one. Let's go to the next one. Yeah, but continue. Take this one.
Okay.
Well,
25-year-old woman present for evaluation of varicose vein. A venous reflex study is performed according to the Society of Vascular Surgery, American Venous Forum. The guideline for duplex scanning for venous incompetent reflux should be A.
Yeah,
Evaluate in supine position.
No, let's wait before you go. This is a very important question because this is like a vascular lab. So because when you decide it's a reflex is significant, okay? And how you do it make a huge difference, you know? So what do you think should be done when you do looking for reflex?
It should be done in standing position.
Correct. And when do you consider it significant? Reflex.
If it is for superficial system, more than 0.5 second. For deep system, more than 1.
It's correct. You know, so this is you have to know these numbers. Okay, this is the way you can tell. Because if less than that, it doesn't work. You know, perforator vein.
I don't know. I don't know the perforator.
Yeah. It should be same and very similar to the perforator system, like but above 300 should be 3 to 500. You know, so it's very similar. All right, so let's go one by one.
So evaluated in supine position, no.
Okay.
Elicited by manual compression and release of the limb proximal to the point of examination. It should be distally, not proximal.
Correct, should be distal. Okay.
Performed with Valsalva maneuver to demonstrate incompetence of the saphenofemoral junction.
Yeah, that's correct, right?
This one correct, yes.
Because Valsalva shows only saphenofemoral junction, Valsalva.
Yeah.
Okay.
And less than 500 millisecond for saphenous, tibial, femoral, popliteal, and deep. No, it is 500 for superficial only.
No, just a second. No. This is correct. This is bumping. Okay. Yeah. But they said less. I mean, the problem is less.
It should be more, not less. Yeah.
So even forget about what the rest they said because they confused. They put the superficial with the deep system. You're right. But because the deep system should be second and superficial should be 500. But here they said less. The more they put less is wrong. You know, even without continuing reading the rest of the question. What about the E?
It should be more than 300 for the perforating veins.
More. See? So anything less, that means wrong. Because it has to be really significant, you know. So when you compress So proximal, you do compress and release, or just only compress, or just release? Well, let's do it this way. And B, what you have to change is the B to make it correct.
First, make it distal.
Yes, this is one option. Next option.
And then you
Take
compress
release.
and
Let's compress. Man, go ahead.
Allah, I'm not sure. I think you
Yeah,
just compress.
Yeah, just compress, because your proximal, you compress, you want to push it back, right? You understand how it's work. You see,
Yes.
if you want to do proximal, you want to see a reflex, you just compress. You see if any reflex. If you are distal, you compress first, so go, and then release to see the reflex. So in the distal, release will show you the reflex. In the proximal, compression will show you the reflex. You follow me?
Yes.
But I got lost.
So if I want to examine the saphenofemoral
Let's go
junction,
back to my drawing, beautiful drawing. Here we are. So go ahead, you can talk while I'm trying to figure out the drawing here.
so I will put the
the
probe
same
on the saphenofemoral junction, and I will squeeze the leg or
No,
the
I'm
distal
saying in
side.
general. Yes. Let me just say, where's the hydro here? What I'm trying to say, this is the femoral, okay? This is the venous vein here. This is femoral, okay? All right. So I'm trying to say, your probe is, let's say, it's here. Okay? You're looking at probe here. See if any reflex. You want to see if any reflex. Screen. Right? So if you come, this is a proximal. This is distal, correct?
Yes.
So if you compress proximal alone, if you have any incompetent valve, we're going to see a reflex because you compress. If the valve are competent, we're not going to see any reflex. So by proximal, just compressing, you can see the reflex. See? In the distal, you have to push the blood first up. So you have to do compression. But when you do compression, the blood will go this way. Then to look at the reflex, you have to release. When you release, you got to see if any blood go back, then you have a reflex. So the distal, you have to do compression and release. This is a reflex. When it's a proximal, you just do compression, then you can see the reflex if there is a reflex. Clear?
Clear. Yes. Can we go back to the question? I think the answer is B.
No, why be? No, you are right answer. Where is it? Let me see. Where's the question? Yeah, where is it? I lost the question. Here is the question. No, look.
Okay, B is wrong.
You see, yeah, wrong because it's proximal. You see,
Yeah.
to be
Yeah.
if they said just they take release, they said elicit by manual compression of the limb, proximal of the limb, it will become correct because they said compression and release. It has to be a distal. All right. Why
Yes.
give you guys this all hint? Because I don't know as the question come in the exam. We try to learn data from the questions. So all this information you learn it because I know how the exam will come. And the same we talk about half a second for superficial system, 1 second for deep system, perforator 300 and above for the perforator. Second thing, the perforator should be more than 3.5 millimeters. Saphenous vein usually up to 10 millimeters. All right, let's do last question because my wife, she started looking at me. She want to go. Let's do one more question. Yahya. Okay, let's keep Yahya. Let's do last question.
Yes, Dr. Samer. A 54 years old woman present with painful varicose vein on the medial aspect of her thigh and lower leg. She has worn compression stocking for years. Duplex ultrasound demonstrate reversal of a flow for 0.75 seconds within the great saphenous vein in the thigh. The great saphenous vein measure 10 millimeter in diameter and located below the fascia until distal 2/3 of the thigh, where it is noted to become superficial to the fascia and tortuous. The great saphenous vein in the proximal portion of the leg is located 8 mm below the skin surface and noted to have a 3 cm segment of acute superficial thrombophlebitis, approximately 10 cm from saphenofemoral junction. A contraindication to radiofrequency ablation would be?
Okay. What's that one by what's the diameter of the vein is contraindication?
What is the contraindication for?
Diameter of the vein. What size should be more than that? Then you cannot do. You know.
1 to 2.
Yeah, more than one. It's like 15 and above. Then it's too big. You know, unless you go. But all this is relative. It's not absolute contraindication, because when you put a tomicin, you can compress it and become small. So all this is relative contraindications. So it should be at least 10 and below. So this one we are fine with 10. We have a 10. This from the skin should be at least how much really?
What, Dr. Samer?
What did this go to be? What the be? Depth of the vein from the skin surface. What's acceptable depth to do a radio frequency?
1 cm to avoid skin.
Okay. Correct. So here we have an 8 millimeter.
This is risky.
So it's risky. But again, it's not an absolute contraindication, because if you do it tomicin, you can push it down. Okay. So it's not an absolute, but you have to put back in your mind 8 millimeters is too superficial. So I have to put enough tomicin to be sure it's pushed down. Okay. We'll go to C.
Tortuosity of the vein in the distal thigh. The absolute contraindication in the proximal part is tortuous in the proximal part.
Because you cannot do radio frequency through it.
Yes.
Then this side doesn't matter, because you already fixed the proximal part. Now your reflex comes from above. So if you do even ablation for proximal, will be enough. So if you have tortuous of the saphenous vein, which is very rare, you don't see usually tortuous, but let's say you have it. So what other option? Because you can use radio frequency or laser. Or even you cannot use a glue, because all is stiff. Then you use a foam. Okay? You can do foam injection. Okay, let's go to D.
3 cm segment of acute superficial thrombophlebitis. It's the right answer.
Yeah, and E.
Duration of reversal of flow.
Yeah, it's not a contraindication, right? This is the reason you want to do it, right? So really, they found only if you have an acute SVT. Okay, it has been acute. If it's chronic, no, you still can do it. But if he has an acute, it's a contraindication to do ablation. 3 centimeter or more. The moment you have an acute superficial thrombophlebitis, I think it's a contraindication. Any other question? Any question before we leave?
Yeah, Dr. Samer, what about tortuous great saphenous? It is, if not candidate for endo, either ablation, the ligation. Okay. It is enough would add stripping in same session.
First, there's nothing called tortuous saphenous vein, because saphenous is always straight. If you look at tortuous, most of you are looking at the branches. And saphenous vein is not there. You see, when you see tortuosity, all the things, this is superficial vein. And the saphenous vein, either too small, you cannot see it, or thrombosed, or gone. Because saphenous vein has to be straight, So you see, out of tortuosity, this is the branches coming from reflex in the proximal. You get a lot of branches and tortuosity in the vein. This one, no ligation. Nobody does ligation anymore. Ligation doesn't work, because you just fix one thing. It's the whole column. So if you just ligate it, it's not enough, because you can get a lot of collaterals, and you have a high chance of recurrence. So nobody do ligation anymore. If you do that, use a foam, because why is contraindicated to tortuosity? Because it's hard to get your wire and catheter all very stiff. So it's difficult to use laser or radio frequency, or even what's the name? The glue. But you can use a foam. Foam is a liquid. So the best for a lot of people is to use a foam. So you just put a pressure on the junction of the 7 0 with the femoral, and you do a foam injection. It will work very well.
Okay.
Any other question?
Thank
All right,
you.
guys. We'll meet Tuesday as usual, right? And then next Saturday, then one more Tuesday. So hopefully by Tuesday we'll finish the venous system. Then guys, decide either we go back to arterial, or if you want to have a question, we can go to an opening question session, or we can go to AV access, or you want to do whatever you want. Just let me know. Thank you, everyone. I
Thank
will
you.
see you Tuesday.
Thank you, Dr.
Take care.